Hello, everyone. Thank you for attending today's webinar, Understanding Common Causes of Failure in Depression Studies, presented by Roe. I'm Joe Keenan, contributing editor for Fierce Markets, and I'll be moderating this webinar. Our speaker today is Jack Modell, MD, Senior Medical Officer at Roe. You can read his full bio on the right side of your window. Just a few technical notes before we begin. If you'd like to download the slide deck, please click the Resources List button at the bottom of your screen. The webcast is being streamed through your computer, so there is no dial-in number. For the best audio quality, please make sure your volume is up. You can find additional answers to some common technical issues located in the Help button at the bottom of your screen. This webinar is being recorded and will be available on demand within 24 hours after the event. We will follow the presentations with a Q&A session. Please submit your questions using the Q&A button on the left side of your screen. You can do that during the presentation. That pretty much covers it. I think we're ready to begin. Jack, please go ahead.
Great. Thank you very much, Joe, and welcome to everybody on the line today. We have, I think, a very interesting presentation covering a lot of matters about placebo response and effect size that really go beyond depression studies. So a lot of this is depression focused, but many of the take-home messages here apply to studies across all therapeutic areas. Before starting, I want to thank Roe for allowing me to present this and for hosting this today, and also give a thank you to my previous employer, GlaxoSmithKline, and the reason for that is twofold. One, great company, but two, a lot of what I'm going to present today is based on data and information that we looked at while I was at GSK, and that somewhat came from GSK databases, and a lot of this also comes from publicly available databases. And to be clear, everything that is in here is at this point publicly available. But a thanks to GSK, a thanks to Roe, and a thanks to all of you for being here today. So moving ahead, I think most folks know now that about half of all depression studies fail to differentiate an active comparator from placebo. Frankly, a lot more than half of all depression studies fail to differentiate, but many of those, as you know, involve compounds that maybe didn't have antidepressant qualities to begin with, which is the nature of drug discovery. But even of those that we know work, still about half fail to differentiate, which ends up costing an awful lot of money, billions of dollars across the industry almost every year. Delays in registration, lost commercial opportunity, and most important from my perspective as a physician, delays in getting new drugs to patients. So it ends up being a very big, costly problem. So the question comes up, how can we improve the probability of success in our studies, which involves not just the question of placebo response, but a lot about study quality, monitoring, and other things that we'll cover today. So one of the first questions to ask is, why do placebo subjects respond? And one of the surprising things I'm going to talk about a little bit later is that placebo subjects don't always necessarily respond. There are a lot of things that are lumped into placebo response that, strictly speaking, probably aren't. But some of the things, at least initially, that are, is that participation in clinical trials is efficacious, meaning that a subject comes in, is now receiving much more attention, receiving hope of improvement, receiving support. Just the idea of coming in and being part of a clinical trial is supportive. So that not just in depression studies, but studies across the medical specialties, perhaps not so much something like oncology, but certainly something like hypertension, for example, or things that may have a significant CNS component, improves because the patient's now part of a clinical trial. Likewise, the act of taking placebo, I think everybody knows by now that even though these may be completely inert ingredients in the placebo tablet, the belief that this pill or whatever the treatment is might be helpful does have some efficacy. The natural history of the disease, depression especially, but a lot of illnesses tend to wax and wane over time, and many of these will resolve spontaneously over time, so there's some improvement that way. Although honestly, over the course of a 6 to 8 week trial, there shouldn't be a lot of natural resolution. Related to that is regression to the mean, and I want to talk about this briefly because people use this term a lot and it's often misused. And what this means basically is that when somebody presents for, at least in this context, when someone presents for medical or clinical care or a clinical study, they're more likely to be feeling worse than how they're feeling on average. So let's say, for example, let's take something like the flu. You have flu-like symptoms. Your temperature is 100. You don't feel that good. You don't necessarily go to the doctor because you think it will get better. The next day you feel a little better. A couple days later, your temperature is 102 and you feel awful. So your illness is waxing and waning. You go to the doctor then because you feel really bad. But chances are 2 or 3 days later, you won't be 102. Even without intervention, you'll be back to 100 or 101, meaning that that's kind of the mean of that illness at that time. But because we tend to seek help when we feel worse, we'll tend to go on those upswings, not just to the doctor, but for clinical trials. So if you take a population of 100 people like that, on average, they will regress to the mean, meaning the mean value of whatever the symptom or the disease is at that point. There's the issue of conditioning. Basically, patients and investigators expect that there'll be some kind of improvement, which relates to patient and investigator bias. When patients come in, and we'll talk about this more lately or later, they feel like they're at their worst. They want to convey that they're at their worst. They want to convey that they really need help, and scores can be inflated in that sense. And investigators also may want a patient in a clinical trial or may want to see them as fitting the inclusion-exclusion criteria, and so may rate slightly higher. Likewise, as the study goes on, there's an expectation that the patient will do better, both from the patient and the investigator standpoint, which can influence scores in the opposite direction. But as I was saying, in a lot of cases, it's not placebo response at all, and we'll get to how that works out in just a few minutes. But there are many factors involved, such as study design issues, site selection, patient characteristics, and investigator and site conduct. It's that last category that will contain the bulk of information about what looks like placebo response but isn't. But in an effort to mitigate placebo response, there have been a lot of discussions at conferences, there's a lot in the literature about how do study design issues, site selection, patient characteristics, etc., influence placebo response, and what can you do to reduce it. So I'm going to start first with a poll question of the audience. And, while I have my favorite answer here, which we will talk about in a couple minutes, I'd be really curious as to your perceptions on which of the following are true. So your choices are that the MADRS generally achieves better drug-placebo separation than the HAM-D. A placebo run-in period generally enhances drug-placebo signal detection at study endpoint. Increasing the number of active arms versus placebo increases placebo response and decreases the chance of study success. Volatility in HAM-D scores from screen to baseline may be predictive of increased placebo response and decreased drug-placebo separation, or all of the above are true. And all of the above, I will say, have been proposed as true at one point or another. So my question to you is, which do you believe are true? So go ahead and vote, and then we'll take a look at the responses in about 30 seconds. Okay, people are still voting. So you've got to pick one. And we'll give just another 5 or 10 seconds. And then we'll go ahead and have a look at the results, I hope. Okay. So the majority, not of people, but of responses here, 39.1% said that all are true. But of the all are true above, the second most common one, or the most common individual one, is volatility and HAM-D scores, may be predictive of increased placebo response. As you'll see from the data analyses that I'm going to present in just a couple minutes, the only one, at least in our analyses and at least my experience, that is probably true is the volatility question, which is actually the one that was most commonly answered by itself. It turns out that although we hear that the MADRS achieves better drug-placebo separation and about the great news about placebo run-in periods and that you shouldn't have too many active arms, in our analyses across studies that had been submitted to FDA, we didn't find those to be true at all. So going through more specifically, we have a blank slide here. I'm not sure if this is supposed to be blank, so we'll go to the next one. No, it looks like we skipped a slide. There it is. Okay. So on the placebo run-in period, if you look through the literature, and a lot of you are probably looking right now to find a study or two or three that says, no, actually placebo response is mitigated by a run-in period, that's true. There are such papers, and there are also those that say that it's not. A paper now that's actually 21 years old, there have been some since, that reviewed 101 randomized controlled trials, actually showed no difference in placebo rates in studies with and without placebo run-in phase. And subsequent studies and our own analyses have shown the same thing. It's not to say that in certain trials you can't achieve a better outcome with a placebo run-in, but it has not panned out to be as helpful as initially thought. Likewise, here's a subsequent study in 2001 in social phobia that showed the same thing. So endpoint selection, there are a lot of HAM-D scales available, and frankly, HAM-D used to be considered the gold standard. There are plenty of other good depression scales. The IDS, the Inventory for Depressive Symptomatology, is actually a very good one. It's accepted by regulators. We don't get into much detail here, but that's an example of something besides HAM-D and MADRS that are available. But with HAM-D scales, there are a lot out there, and you need to consider one that's specific for the drug or the target population. So for example, when we at GSK did studies in seasonal affective disorder where, patients who are affected often describe feeling like they were hibernating during winter, we looked at and chose some HAM-D endpoints that actually favored the neurovegetative signs and some of the atypical signs and symptoms of depression, like oversleeping, overeating. So you want to look at these if you want to use a HAM-D scale, but true for any scale that is relatively specific for the drug or the target population. The HAM-D21, this is probably common knowledge by now, has 3 items that are particularly insensitive to depression, basically to changes in depression as it's treated. So I would avoid scales that have things like depersonalization or derealization, which when the scale was developed several decades ago now was thought to be part of depression. It can be, but it's not specific. Paranoid symptoms, normal non-psychotic major depressive disorder, the patient should not be paranoid. Likewise, obsessive compulsive symptoms, which used to be considered part of depression, really are not. So you'll want to avoid scales, again, that have a lot of these kind of symptoms or other symptoms that don't change in depression. There are some specific HAM-D subscales which can be used as primary or secondary outcomes. And this came from a meta-analysis now a while ago in the year 2000 looking at randomized controlled trials with fluoxetine and tricyclics using the HAM-D17, and this has been subsequently confirmed, to show that there are 2 subscales that have significantly greater effect sizes than the HAM-D17 total. The Beck, not to be confused with the Beck Depression Inventory, that's a K, this is an H, and the Meyer, which you can see the items there. And basically these are items having to do with depression, guilt, work activities, work and daily activities, psychomotor retardation or agitation, anxiety, and generalized somatic symptoms. things such as suicide or suicidality actually didn't make the cut. And it's not that suicidality is not fairly specific for depression. I mean, it can occur in other things, such as some of the personality or impulse control disorders. But most patients in depression trials aren't reporting suicidal ideation. Not because they don't have it, frankly, but because they're scared to tell you about it. So you have to, again, look at things that are commonly reported as positive in depression and then get better with treatment. So what about the question of the screening versus baseline Hamilton and the change in the HAM-D between the two? So there have been a few studies by us at GSK and others, and here are 4 studies in which patients were not excluded if there was a lot of improvement in HAM-D between score and baseline. And when these were analyzed, what we found was that patients who actually had marked improvement between screening and baseline showed poor drug-placebo separation. So perhaps not surprisingly, if they come in and they've got a HAM-D score of 25, and a week later at baseline their HAM-D score is 18, they're already headed in that improvement direction. That could be your regression to the mean. It could be a placebo response. Could be from support. Could just be that the depression's resolving. But we also saw that patients who worsened a lot, and our cutoff was plus or minus 25%, who worsened between screening and baseline showed the highest placebo response and the poorest drug-placebo separation. Hard to say exactly why that was, but I will tell you, and you know this if you've treated a lot of patients with depression, generally they're plus or minus, I don't know if it's 10, 15, 20%, but of their symptoms day after day. They're not bouncing around a whole lot. They feel awful one week, and they feel awful plus 10% the next week, and awful minus 10% the next week. If they're going from feeling really bad to, they probably won't feel really good, but much better, or moderately bad to much worse week after week, there's a good chance that you're dealing with something that's more reactive or reactive depression, or something that may be personality related, or a patient, if they're truly worsening, who may be getting into clinical difficulties and not ideal for a clinical trial anyway. So the conclusion from our review and also other reviews is that volatility in HAM-D scores from screen to baseline may in fact be predictive of increased placebo response and decreased drug-placebo separation. So very commonly, we would use, and I still recommend using, a cutoff that if there's more than there's some argument over this, say 15 to 25% change, I think 20% is reasonable, up or down between screening and baseline, these patients should probably be excluded from your depression trials. Unless for some reason you want to study the effect of something on people who have a lot of volatility. So another thing that I heard and still hear repeatedly is all the key opinion leaders say the MADRS is better than the HAM-D, and you could substitute any other scales in there as well. But we wanted to take a look at this, and so we looked at 44 different drug versus placebo comparisons that had been submitted to FDA for review, reviewing the antidepressant registration studies, HAM-D and MADRS, including citalopram, mirtazapine, venlafaxine, IR, and XR. And of the 44, we saw that the HAM-D won, if you will, because these studies had the HAM-D and the MADRS, and the HAM-D had a better separation in 20. So not looking great for the HAM-D, but the MADRS won in 20, and there were 4 ties. So, even if the true answer is plus or minus 10 or 15% of that, it actually didn't point to the MADRS being more sensitive. So what about the ratio of active to placebo arms? And the question of whether increasing the number of active arms increases expectation of drug effect and therefore placebo response. It sounds like that ought to be the case. If you tell the patient you have a 3 out of 4 chance of receiving an active drug, you'll have a greater placebo response. But in fact, although it sounds good, it's not supported by the literature or analyses that we've looked at. Frequency of subject contact, Does increased contact through the study increase placebo response when you actually look at the data? Probably not. So what about site selection? Now, this is a little complicated. I'm going to spend a fair amount of time on this because it can be a little bit confusing. So when you don't control site selection for site quality, so in other words, you're looking at studies that have already been completed and kind of lumping all the sites together, what's the relationship between the number of subject sites and number of subjects per site and study outcome? So looking across 20 studies, across 4 marketed antidepressants, the number of sites, not significant. The number of patients in the trials, not significant. And this is for marketed antidepressants now. So these are approved drugs. So there is some bias in here because this particular analysis doesn't look at the studies that failed to get approval. But at least in what was approved, no significance for number of patients or number of patients per site. So the take home might be it doesn't matter, but actually I think it does. And it looks like we may be coming back to that a little bit. So looking across 2 antidepressant databases for factors affecting study success, large N. What about duration of disease? Well, we actually found that if the duration was less than 6 months, there was less drug-placebo separation. Maybe not surprising because if it's less than 6 months and especially less than 3, you may not have a stable illness yet. There may be some question of whether they're eventually going to fully qualify for major depressive disorder or whatever the diagnosis is that you're looking at. And patients who were sick for more than 20 years, not surprisingly, had less of a drug-placebo separation, frankly, had less improvement at all. But the interesting thing is, 19 years, 15 years, 10 years is a long time too. Yet we did not see much effect between 6 months and 20 years. So I've seen studies that say, if you've been depressed for more than 2 years, you shouldn't be in the trial because you're not likely to get an antidepressant effect. That's actually not borne out. You really get a very wide window there. So depression score at entry, not significant when rated by the investigator. So commonly, you'll see people say, well, we want to have a cutoff of 15. No, let's do 18. No, we better do 22. We better do 25 to make sure we get the really sick patients. If you just look at investigators and how they rate that and the different cutoffs, that doesn't seem to matter because as you'll see, for better or worse, and I would say really for worse, investigators and or patients end up biasing their scores such that wherever you set that cutoff, most of the patients qualified. It's interesting that there was one study, and I don't think I have details on this in the slide, so I'll mention it, where Eli Lilly did a study where it was IVR, interactive voice response, self-rating, where they had no cutoff. Patients could get in wherever they fell as long as they met criteria for major depressive disorder by a careful diagnosis. And that study separated very well drug from placebo because there was no bias, there was no influence to say they had a certain score when they came in. And therefore, a week or 2 later in the study, and you'll see examples of this, there was nothing that would promote them to say, okay, I'm a whole lot better now. They might just feel a little bit better because maybe they were only a 16, let's say 20s moderate depression, and a week or 2 later they were a 15 or 14. So they basically were allowed to rate wherever they were rather than where an investigator thought they should be or needed to be to get into the study. Presence of an active comparator and placebo doesn't decrease the probability of success versus a study with placebo only. The number of treatment arms in these analyses did not prove to be significant. The probability of getting placebo in the study was not a significant predictor. Flex versus fixed dose. You often hear that one is better. Fixed is easier logistically, but one did not give better probability of success overall. Again, we found presence of placebo run-in our own analyses, not significant. Whether they were currently getting psychotherapy, not significant. Duration of study, was interesting in that the maximal separation for depression studies and most of the anxiety studies occurred at 6 to 8 weeks with minimal gain beyond. So unless you are testing a drug that you don't think will work very well at 6 to 8 weeks, in which I would say you better question the commercial viability because your marketplaces with drugs that typically work in, depends on how you define it, but 2 to 6, there's not much sense in going beyond 8. And what's interesting is we did see a lot of separation at 2 to 4 weeks in almost all the antidepressant trials with known antidepressant agents that were effective. However, I would recommend 6 to 8 because you want to show duration of sustained response. So the number of visits turned out not to have effect. The number of visits divided by the duration of the study, so the visit intensity, how frequently were they being seen relative to the study duration, not significant. Early versus late enrollers, not significant. But a few things turned out to be statistically significant, but I'm not sure that they're in fact that meaningful because you'll notice here we've already done like 15 analyses. So we've got the problem of multiplicity here, so when something turns out to be significant, doesn't mean you need to rush out and do this in your studies, but something that was interesting is we felt ahead of time that if you give too many questionnaires, it may be too much patient or investigator burden, and it might make them give up or might make them feel more attended to, and therefore the number of questionnaires might significantly affect placebo response in an adverse way. We actually found a p-value 0.03 that the more questionnaires had a better probability of success. So again, don't add more questionnaires for this purpose, but it clearly looked like the number of questionnaires alone isn't decreasing placebo response. One of the biggest factors, I think most folks know this, is the study year, when the studies were done. Drug placebo separation has been steadily shrinking from the 1980s until now. And what's interesting, in the 1980s, and actually before, the drug trials tended to be smaller. We didn't have research mills back then. They tended to have fewer investigators. Patients maybe didn't have as much expectation that they would have a drug effect. And so for all of these reasons, unfortunately, the drug placebo separations have been shrinking since the 1980s. This was interesting, too, that the N was significant, but I'm going to give you some data in a bit that suggests that this statement here has some confounders in it. So all of the studies that had an N of less than 50 failed. And of those with an N of greater than 100, 6 out of 9 were positive, 2 out of 9 were trending. But as I mentioned, the early antidepressant studies often had Ns of 20 to 30 subjects per arm, and they succeeded very nicely. So what this is saying is the Ns nowadays in studies, if you only put in 20, 30, 40 patients, chances are, unless you've got a really whopping drug effect, this study is going to fail. And one of the things I've seen now at Roe is that we get a lot of sponsors who come to us and they say, you know, we want to see if this drug works. We don't have a lot of money. We only want 25 per arm. And again, this could be for depression or other things. We just want a signal of efficacy. The problem is the chances with small studies in general is you're not likely to get a meaningful signal of efficacy. Yes, the drug arm may have a mean change of, 10 points. The placebo arm might have a mean change of 8 points. But in a low-powered study, that's not a meaningful signal. There's a very good chance that 10 versus 8 is just chance. And for a company to say, well, it's looking good, and now we're going to invest $5 million into the larger study, there's a very good chance you're going to lose that money. So the point being, a study should not be done, especially a proof of concept study, that is knowingly underpowered because the results are not likely to be interpretable. Not just likely not to be statistically significant, but you may get a lack of a response when there truly is a response. So that is a false negative. And you may very well get a false positive where it looks like you have a trend. You then do your larger study, and unfortunately, you've wasted your money because it was just differences in the normal distributions. Another interesting finding that came out of this is that subject participant sex was significant. Studies with higher percentages of females in depression are more likely to fail. Why that is, it's not entirely clear. The prevailing idea is that women are more likely to seek help early on, perhaps when they need it more, and I think that's good overall. Men are more likely to wait until they're more severe or until they basically can't face it or admit to facing it on their own and they need help, whatever it may be. But the studies with greater percentages of men relative to the others did a little better. And depression, as you know, is an equal opportunity employer. It hits people of every age, sex, race, ethnicity. And so it's not a bad idea in general to try to get an approximately equal percentage of men versus women in these studies because those are the patients who need the drug and will benefit. But also if you end up getting disproportionate numbers of females in the studies, which often happens because they're more likely to present, you may be increasing the risk of study failure. So that's just something to keep in mind. So there's another big question about, well, should we just exclude all the sites that have a large placebo response? Because maybe that uses up available drug response, resulting in decreased ability to detect drug-placebo differences. And we did some analyses by study and analyses by investigator, which I'll go through that in just a minute. But the results were somewhat interesting. So the first question, does a higher placebo response mean a lower drug-placebo separation? So we had a look in one database, and you see the results in the graph in the upper right. You might look at that. So the labels are a little hard to read, but basically on the left is the drug versus placebo response, and the labels on the x-axis, the horizontal axis, is placebo response by percent, as high as 50% on the right and looks like 15% on the left. So you look at this line and you say, whoa, look at that. Yeah, the higher the placebo response, the lower the drug versus placebo effect, or basically the lower the chance of success. But if you actually look at the data, let's see if we can come down here to this R squared adjusted. So the interpretation of R squared, which in this case rounding is 0.23, would be that 23% of the variability across these studies was due to placebo response. So you say, well, is that significant? And I can barely read this without my glasses, but it looks like that p-value is 0.03, and you say, yes, that's significant. But here's the issue. What this is telling you is that if 23% of this fit, if you will, is due to placebo response, it means that 77% isn't. So placebo response in this analysis does have an effect, with sites having higher placebo response, having a lower overall drug-placebo separation, but that only accounts for 23% of it. So not a huge driving factor. So just looking at placebo response at a particular site and saying it's a little higher than other sites is probably in itself not enough reason to disqualify the site. So we then looked at a second antidepressant database and said, could we replicate it? Well, you still see the same slope, but in this case that R squared is 0.07 or 7%, and in fact the p-value was not significant. It doesn't mean that placebo response shouldn't be looked at, and we will look at that more closely. But it does mean that that alone is not a huge predictor of how a site is going to do. And we also looked at something interesting. We looked at a couple of sites, and I know you can't, at least I can't see what this stuff here says, but this is one site in particular who had done a whole lot of studies. And this is placebo response, which for some reason is running greater this way. But whichever way it runs, you can see it was completely flat. The amount of placebo response within site across different studies didn't seem to affect study outcome that much. So let's look at investigator and site Misconduct, which will tie a lot of what we've talked about so far together and hopefully make it a little bit clearer. So one of the things, and this is actually what made me look into a lot of these questions when I came to GSK, is I was shocked that there was a 50% placebo response in a lot of studies. Because for 20 years, I had been treating patients with depression. And patients with severe depression or even moderately severe depression didn't get better just because I was nice to them. Didn't get better just because they had seen their primary care and 2 other doctors before they saw me who gave them vitamins or gave them TLC, not to say that TLC isn't important, it is, but they didn't get better with what we think of as placebo response. And in fact, a lot of my more severe depressed patients looked a lot like my Parkinson's patients, and I don't mean the motor symptoms, but that they would sit there and they would have this psychomotor retardation. They would be sad. They would have a paucity of motor activity. And yes, and I didn't do this, so I'm exaggerating, but if I shouted at them or shook them or somebody yelled fire, they would jump up and they would look like they had full energy, but not for more than a couple of minutes. So what I noticed that in clinical practice, they did not, and this is not just depression, but other psychiatric illnesses, they don't generally improve with support or encouragement alone. And frankly, they often do not or will not participate in clinical trials. If you think about it, and a lot of us have been depressed ourselves or our family have, so we've seen it. If you've got someone who can barely go to work and is having trouble getting up in the morning, and they can simply go to the pharmacy and fill a prescription for an antidepressant, but you say to them, hey, maybe don't do that. I have this great clinical trial where you got a 50-50 chance of getting placebo and a 50-50 chance of the experimental product working, but we'd love for you to be in this. Do you want to do this? Most of them are going to say, thanks, that's very nice, but I just want something to get me out of this. So that's a huge systemic problem that may be contributing to the difficulty we have with getting the right patients that we've seen more and more over the last 20 or 30 years when effective and generally well-tolerated antidepressants are available. So getting the right patients now is getting really a whole lot harder, unfortunately. So that brings up the question, are inappropriate patients being inducted into trials? So as we've talked about, the more severe patients generally don't participate. And there are some exceptions to this, obviously, which is a whole different topic. But maybe folks who don't have easy access to health care or, for whatever reason, they want to stay with that physician or investigator or are invested in clinical trials, perhaps because they've had family members suffer and, want to advance the field a little bit. But often the more severe patients don't. But the other issue that comes up is deficit in rater assessment skills and or limited value of traditional training. Very often, investigators are trained in kind of a wholesale way at investigator meetings and site trainers. We don't have a lot of time to go into it, but I've seen a lot of cases where these folks have been shown videos of severely depressed patients or asked to rate depressed patients. They can't or they don't rate it very well. We'll go back in and I say we just in general in clinical research and say, okay, let us teach you again the proper way. They still don't do it very well. And somehow a lot of these sites are included anyway. And I cannot stress enough that if you've got raters at sites for whatever the illness who can't properly rate, frankly, even the first time through, but definitely by the second time, don't include those trials or those trial sites and or those raters, because I'll show you examples coming up of what happens when you do. You basically get raters that can't rate and you don't separate from placebo. There is intentional bias for incentive, both on the side of the subject who may want to be in the trial and the investigator, which can lead to bending inclusion and exclusion criteria a lot. I'll give you a quick example. In a study that I actually did, one of my cousins up in Chicago at the time participated. And he called me afterwards and he said, you know, they asked me questions about how often I've been depressed, how severe my depression was, and I gave them an honest answer. And they came back and they said, well, are you sure it's not a 3 out of 4 rather than a 2 out of 4? Are you sure it's not 9 months out of the year versus 8 months out of the year? And basically the sites were coaching him, perhaps unintentionally, to qualify for the study trial. And he said he very easily could have said, yeah, you know, maybe you're right. Maybe I am a little worse. Maybe I'm underestimating. But in fact, he didn't participate. He called me instead and said, hey, you better check out this site because they really seem to want to get patients in, and that's going to influence your results. So this problem is particularly problematic when the inclusion-exclusion criteria are poorly written, which happens all the time. I can't stress enough the importance of having these criteria to be explicit and written well and leave little to investigator judgment. And I often see sponsors go the other way. They say, no, we trust our investigators. Just say an investigator's opinion. Investigators' opinions vary widely, and if there are certain types of patients you do or you don't want in your clinical studies, you need to be explicit. And on this next slide, I have an example of even where we were explicit, but it shows you the kinds of thinking that happens at clinical sites. And it says it's not responding. So before we get on to this, anything we can do to make this respond? Try it here. There we go. Sorry, we're having technical difficulties. Clicking here doesn't do it. Try click to recover. Try that. Okay. Hold on, we're having technical difficulties. Okay, can you advance the slide for me, please? Not the listeners, but our moderator here. Although if any of you listeners can do it, please do. Is our moderator with us?
I'm still with you. I believe Grace Savine is offline trying to work on it right now.
Okay, thank you. All right, sorry about this, folks. Okay, I see that it says I've got the advancement. Hold on a sec. Okay, I can't see the slide that's showing. Whoever advanced it, can you tell me what the title of the slide is?
Jack and Joe, the 3 of 3 animation.
Okay, I need the slide that says email from a site about exclusion criterion. Yeah.
That's what I have on my screen.
Okay, good. All right. So this is an example where I get a question. This is a criterion that I think is pretty well written, and the site says, good afternoon. The exclusion criterion that the patient currently meets states recent history within 6 months of screening of alcohol use disorder or substance use disorder as defined in DSM-5 or a positive drug screen at the screening visit. And hold on a second. Okay. So they had a question for me as the medical monitor. If it is determined by the physician that the patient does not have a recent history of substance use disorder, that this positive cocaine drug screen is just a one-off and not indicative of an underlying substance use disorder, being as the patient does not endorse the other criteria for meeting the diagnosis according to DSM-5, can we enroll the patient? And I'm like, really? So a patient turns up positive on a cocaine drug screen and the patient says, no, I'm not using drugs, and they want to put the subject in. So again, you can't be too explicit. Frankly, I was a little worried about this investigator who would think that if you have cocaine in your urine, it was just, their friend was using it or whatever it was. So let's go back. I'm going to speed up a little bit because of time right now, including known personality disorders, recycling patients, misconduct. I hate to bring this thing up, but we do see, and when I say do see, I'm not just talking about Roe or GSK. I'm talking about my 35-plus year experience in clinical research. There are investigators, nice investigators, fun investigators, friendly investigators, investigators whom you wouldn't suspect, who are intentionally, I hate to say falsifying data, but intentionally making data come out to look a certain way. There are a whole lot more, frankly, who do it unintentionally, but there is misconduct out there, and I'll just say quickly, there are statistical programs out there that will help you spot trends in the data during the trial that suggest misconduct. But most commonly what we see, and this is where this placebo response issue really comes in, are investigators inflating entry scores. And what this ends up doing is giving you post-baseline ratings that look like but aren't placebo response. Because what happens is if you tell the investigator they need a 20, whatever the scale is to get in, a week, and everybody gets a 20 or 20 above, a week later, that inflated score is no longer necessary. Patients and investigators want to show improvement, and frankly, patients and investigators want to try to guess the treatment arm. And so you don't necessarily see that inflation anymore. So maybe a little more graphically, here's what happens. If that vertical blue line there, on whatever scale you're using, is the cutoff, so to the right patients get in, to the left they don't, and let's just say that's a HAM-D of 20, and you have a bunch of patients come in, and let's say they are on average a HAM-D of 20, about half of them will qualify and half won't. But we typically don't see that in our clinical trials. What we see instead is a curve that looks like this, where the vast majority qualify, and the vast majority are at or just beyond that cutoff. So then what happens after a week, so let's look back up here in the upper right. That's the same slide that you just saw. So these patients were basically what they actually had presenting. The investigator basically took all or most of these and shoved them up over here. But in truth, they're really this whole bit. And so what you see a week later, now I'm just taking this half, these subjects here, they've slid maybe a little bit to the left. They've gotten a little bit better. But because the investigator didn't rate them that way, you now get this whole thing way over here. So to put this more simply, what's happening is all of these guys who probably shouldn't have gotten in the first place, who were pushed over here, now are part of your experimental population. And it looks like you've had a huge placebo response, way beyond what really would have happened if you had just included the appropriate subjects. So what about interactive voice response? Basically, subjects rating themselves without the investigator's involvement. It really helps a lot. This is actually showing a couple studies, which is going to show you the same thing I just showed you with those graphs. This is a study where the clinicians were told that the subject needed a Hamilton A for anxiety, score of 20 to get in. And lo and behold, everybody who presented had a score of 20 or above. But when you ask the patients to rate it themselves without telling them that they needed a 20, not that they would have known what that was, but that's what the patients said. There were some that didn't have anxiety at all, that with the investigators, they all got in the study. So then what happens a week later? So this visit 2, actually it gets more complicated, but visit 2 was the qualifying study. So you look here, this is the way the patients really looked. This is how the investigators said they looked. This is basically the correlation between the two. And the investigators actually were tricked a little bit, and they were told that the subjects were randomized right here, but they actually weren't. And so the investigators still said, look, they all qualify. Well, the patients, most of them didn't qualify, or half of them didn't. And once you told the investigator that the subject had been randomized, even though you didn't treat yet because the actual randomization didn't happen till here, look what happened. Suddenly all the patients look better. It looks like a placebo response, but what's really happening is the investigator no longer has incentive to call these scores at 20. And then a week or two after randomization, you look at the investigator scores, the patient scores, and now they correlate really well. So moving ahead, and I'm sorry I'm rushing just a little bit, this is just a study that Lilly did with and without IVR involving placebo. When clinicians rated Prozac, you know Prozac works, it really does, didn't separate. Duloxetine did, interestingly, but the Prozac arm didn't have as many subjects. But if you look at when the patients rated it themselves without this bias factor, that did separate from placebo. Initial computer interviewing, this was one of the very first IVR machines. Computers have definitely changed. This machine, I actually had to look it up. How much RAM did it have? 4K, not 4 megabytes, not 4 gigs, but 4K. And in today's money, cost about $400,000. All right, so quick question here. The percentage of study sites, unintentionally or otherwise, that seem to bend the rules, rate poorly or with bias, or fail to understand protocol requirements, or otherwise fall short of giving adequately objective study data, seems closest to which of the following? Now, let me just say, this is in your experience. So I've been telling you that there are problems with study sites. Obviously, I don't think this answer is less than 10%, but I don't know the answer. And everybody's experience is going to differ. And so I would be really curious in your own experience, what percentage of study sites do you think that intentionally or otherwise bend rules or don't give truly objective or high quality data? And by the way, we are not matching your response to who you are. So you can say whatever you want, and if it's high or low, we're not going to come after you and say, geez, tell us more about this experience. So go ahead and vote on this. Most of you probably already have because I've been carrying on about this for too long. And last 5 seconds, in your experience. So thank you. All right, well, this is interesting. All right, so it's good that 17%, or maybe good, say it's less than 10%, but 45% are saying 50%, and 12% are saying greater than 75, which means that the majority of you are saying that half or more than half of study sites are not giving us good quality data. That is very consistent with my experience. It's sad but true, and a reason why study site selection, and if you're using a CRO, whatever CRO you're using or whatever clinical operations group you're using, really vets these sites carefully because, yes, this is a huge problem, and there are lots of things we can do to reduce it, but unfortunately can't make it go away. Okay, and now we're on the next slide where there we go. All right. Unfortunately, because of time, I'm going to need to skip through some of these or tell you very quickly what happened here. But basically, one study, if you let interactive voice response technology rather than the investigator choose your subjects, you can end up getting rather robust drug placebo separation. This is with Wellbutrin XL, and you can see we even have separation at week 1. Because in this case, this is clinician rating. We told the clinicians that IVR was going to be cross-checked with their ratings and there better not be any scale inflation, and basically there wasn't when IVR was used as the standard. What about just increasing sample size to increase power? Let me just say, I'm going to have to go through this quickly. I'm sorry to do this to you. But the answer is, don't just increase sample size to increase power, because increasing sample size will not increase power unless all of the sites are of similar quality And typically what happens is when you get larger sample sizes, you include sites that are not necessarily of known quality, or even sites where you say, gosh, not the greatest quality, but we've got to, enroll 200 subjects. And this is, again, something we did at GSK, where we looked across several studies, and this was assessed prior to unblinding in studies, where we basically looked at effect sizes by all the sites that were chosen, by the sites that we wouldn't have chosen, that's the yellow, if we didn't have to include so many subjects, and the sites that we decided a priori should give us great results, not because they enroll a lot of subjects, not because marketing necessarily liked or didn't like them, and that wasn't a factor anyway in our GSK studies, but basically whether or not these sites were known to have high quality, good drug placebo separation when the drug works. And what we found consistently was much bigger effect sizes if you just include sites of known high quality. So what's interesting to look at is the N required for statistical significance. If in this case we had just included the sites that we knew were good, an N of 200 would have done it. An N of 484 was frankly required given the sites we did pick, and yes, this study did fail at a 0.05 level. And if we had just included the sites that we kind of added on because we wanted to increase the sample size, it would have taken an N of 40,000. So increasing sample size by adding sites of unknown or lesser quality, not a good thing. Here's a little more reasonable numbers here, but you can see the same effect. So in summary, many, if not most, study failures with an active antidepressant compound may be due to inappropriate subject selection and ratings that, to put it tactfully, are not fully objective. Investigator and site selection based on actual performance data, quality, drug placebo separation when you know you have an active drug, and frankly, lack of separation if you later look back and you know something didn't work. That's of greatest importance. Choosing only sites known to produce high-quality results may enable considerably smaller sample sizes. The corollary to that, increasing the sample size to increase power, I put that in quotes because it doesn't work, may be counterproductive. Training has to be optimized, and I can't stress enough that oversight of study conduct has to be rigorous for protocol compliance and understanding. As nice and well-intentioned and trained as many investigators and sites are, they've got to have very active monitoring. Study inclusion-exclusion criteria should leave little to investigator judgment. Use of IVR can help tremendously, and that is accepted by FDA. I mean, talk to them first. Don't just take my word, because certain exceptions may apply, but that is accepted as a primary outcome measure. Use of enrichment and enforcement focused on core symptoms. That's the part I glossed over, but basically core symptoms of the illness are really important. So for depression, lack of pleasure, lack of interest, lack of energy that almost all depressed subjects have, as opposed to things like that depersonalization, derealization, suicidality, which they may or may not have or report. It's really important. Relatively little to support the specific scales, severity requirements, or study designs other than IVR in themselves enhance signal detection. Sites with larger placebo responses don't always have lower drug responses. And experience in study design, site selection, study oversight, and data analysis really matters. So if you have that experience internally, that's great. If you don't, find somebody who can help you, because clinical studies are just obviously not something you just want to get into without terrific amount of experience and quality control throughout the course of the study. So I have managed to leave 1 minute and 10 seconds for questions, and I'm sorry about that. Do we have some questions?
All right, we have quite a few questions, Jack. I think with the time we might be able to get to two of them. There are a lot of great questions, and we won't be able to get to them all, but we'll be getting back to everyone who did submit personally after the webinar. We'll just move right into it. Is there some way to know during the course of trial whether a site may not be objectively assessing or recording data?
Yes. That's a great question. Couple ways. One, as I mentioned, there are statistical packages that can help you do this, but you can also do it by visualizing the data on your own. So if, for example, and we've seen this, you get subject weights or vital signs that don't change. I remember one study where the weight at baseline was 70.0 kilos, and then a week later 70.1, a week later 69.9, a week later 70.1. Wouldn't you love it if your weight only changed by a few ounces, from week to week? So you see something like that, there's a very good chance that data aren't being looked at objectively. We've also seen patterns in data that even suggest that all subjects are having the same rates of improvement or time course of improvement, so things aren't looking objective, they're not looking normally distributed. Can also see examples of where sites have favorite values. Might be 5s, might be 2s that they put in. So there's a lot more to that answer, but generally looking at the data, I don't mean unblinded data, but the aggregate data during the study itself, you usually can spot things that don't look normally distributed or don't look like they occurred naturally. And the most obvious is, as I mentioned, the baseline scores. If everybody or 90% of your subjects qualify, there's a problem, especially when the majority of them are just above that cutoff, because that's not what you would expect with the normal distribution.
Unfortunately, that's going to wind up our Q&A session. Thank you for attending this Fierce Markets webinar and submitting so many great questions. I'd like to thank our speaker for participating and Ro for presenting today's webinar. The webinar has been recorded. You will be able to access the recording within 24 hours using the same audience link that was sent to you earlier. Thank you again for joining, and we look forward to seeing you at future events.
All right. Thank you very much.